Good afternoon. In today's presentation, I'm going to talk about a molecule that we have recently encountered being used in metabolic acidosis, THAM in the management of metabolic acidosis. I'm going to talk about practice experience and some evidence in the literature on the use of this molecule in metabolic acidosis. As an introduction, I would like to refresh our memories about the adverse consequences of severe acidemia. It includes cardiovascular effects, which includes centralization of blood volume by means of arterial dilatation and venoconstriction. There is impaired cardiac contractility. At the same time, the cardiac conduction system is increasingly sensitized to reentrant arrhythmias, and the threshold for ventricular fibrillation goes down significantly, leading to devastating cardiac arrhythmias. There is attenuation of cardiovascular responsiveness to catecholamines. There is hyperventilation and shortness of breath, which eventually leads to respiratory fatigue. There is an increased catabolic state by means of increased protein degradation, increased metabolic demands, insulin resistance, reduction in ATP synthesis. In the cerebral system, there is inhibition of metabolic pathways leading to reduced metabolism and cell volume regulation. And eventually, as a consequence of severe acidemia, when the pH goes down significantly below 7.2, there is always a risk of obtundation and coma. When a clinician finds the tissue pH or arterial pH below 7.2, in order to avoid the metabolic state, a reflex phenomenon is to administer alkali. The most common alkali that we use in clinical practice is sodium bicarbonate. But there are risks involved in using sodium bicarbonate in a florid acidotic state, and the risk includes increased carbon dioxide generation and tissue hypoxia. And the next slide demonstrates how this is chemically possible. When we administer bicarbonate to buffer the acids, it eventually forms carbonic acid, which by the help of carbonic anhydrase gets converted to free water and carbon dioxide. Carbon dioxide, or CO2, is easily diffusible across the cell membranes, and it causes intracellular acidosis by reducing the pH. In a study in anesthesiology literature, it was shown that rapid intravenous administration of 50 milliequivalents of sodium bicarbonate would generate approximately 1 minute's worth of carbon dioxide. There is always a risk of overshoot alkalosis with sodium bicarbonate infusion. In an acidotic state, there is respiratory compensation by CO2 washout, and if the rate of alkali administration goes faster, what eventually happens is the patient ends up in a state of metabolic alkalosis, and the respiratory compensation has not catch up with that. And this is a state of overshoot alkalosis, which in a patient with severe acidosis and compromised respiration could be detrimental in terms of respiratory failure. The nature has its own way to utilize the alkali. When we give alkali to the patient, it stimulates 6-phosphofructokinase activity, and this allows partial regeneration of depleted ATP stores in the vital organs, and this is important for survival. But this comes at the cost of increased generation of organic acids, which can eventually worsen the acidotic state or acidemia. The molecule that I'm going to talk about today is tris-hydroxymethyl aminomethane, or THAM, which is the trade name. It is a weak base, it is an amino alcohol, and obviously it is an alkalinizing agent. In one of the reputed journals in 1966, THAM's physiological effects and clinical usefulness was mentioned. I won't say for the first time, but it was mentioned in an elaborative fashion. To simply understand the mechanism of THAM, as it's a weak acid and a buffering agent, it buffers the free acid, and this would eventually free up the bicarbonate which was originally used for buffering. THAM also combines with products of carbonic acid, that is water and carbon dioxide, to generate bicarbonate. So this carbon dioxide is utilized to generate bicarbonate and get the buffer released. So since the carbon dioxide is utilized here, theoretically this should prevent intracellular diffusion of carbon dioxide and prevent intracellular acidosis. This is the effect that we are looking for, and this is the effect that we don't get when we use bicarbonate. So the practice experience that I'm going to discuss today, which was found in the literature, is done on few patients in the critical care unit in San Francisco General Hospital, and this experience was published in American Journal of Respiratory and Critical Care Medicine in 2000. Acute lung injury, which develops as a consequence of sepsis and trauma, is usually associated with a grave metabolic state where we have severe metabolic acidosis, shock, and multi-system dysfunction. The current surviving sepsis guideline has allowed permissive hypercapnia as a strategy to avoid further lung injury. In the early years, hyperventilation was used to correct acidosis, but this has shown to cause more barotrauma and prolong the length of stay and increase mortality by worsening the lung injury. Again, as I mentioned, when the pH is dangerously low, emergent use of buffers is warranted to restore an acceptable pH at which the cellular function can be at least close to optimal or suboptimal, and the effects of vasopressors at least are bare minimum for survival. In a severe acidotic state, we won't get the desired effects of vasopressors. The dissociation coefficient of THAM allows it to have a wide range of buffering capacity at various pH. The pKa of THAM is 7.82 versus 6.1 for the bicarbonate. So not only THAM is available during the initial correction phase of acidosis, but it's also available for a persistent correction. And again, as we know that theoretically it has the capacity to buffer both metabolic and respiratory acidosis. So this is the range of pH at which THAM is available in ionized form to act as a buffer, and we can see that it has a wide range of pH at which THAM in circulation is available in ionized form to buffer the acids. Protonated THAM is excreted by kidneys so that the carbon dioxide production is not raised. It's not excreted by respiratory system. There is no need to increase minute ventilation and cause further barotrauma. As I clarified in the beginning, this article does not depict a study, but it's a practice experience. The patient mentioned in this study or in this literature or in this publication were patients with acute lung injury who received THAM in between March 1994 and March 1989 at San Francisco General Hospital. And again, there was no study protocol here. The decision to administer THAM was made by the treating physician based on their experience, clinical criteria, and their judgment. The 10 patients who were mentioned in this publication were usually in the younger age group. The oldest patient was 58 years old, and they had multi-organ dysfunction, sepsis, metabolic acidosis, and acute lung injury. And the clinical scenario varied all the way from necrotizing pancreatitis and septic shock to necrotizing pneumonia and septic shock, or neurogenic pulmonary edema, gunshot wounds, hepatic failure and septic shock, AIDS, and pneumococcal pneumonia. And I'm not going on to the details of each and every patient, but this is the usual variety of patients that we see in critical care unit. The only difference is this study does not mention anything about patients age 60 or above. The patient had a fairly high lung injury score and poor lung compliance, as demonstrated by these numbers in the patient characteristics. In 7 out of those 10 patients, THAM was given as IV infusion at a rate of 0.55 millimoles per kilograms per hour. This was the mean rate. The average length of treatment was 39 hours, and it varied all the way from 2 hours to 96 hours. In 3 out of the 10 patients, a bolus dose was used as a rescue therapy, where they used 150 to 200 milliequivalents over 30 minutes to 1 hour intravenously. The 3 basic data that was studied include arterial pH, the arterial carbon dioxide tension, PaCO2, and base deficit. And these data were analyzed 1 hour prior to the infusion and within 2 hours after the infusion was started. And you can look at this table and see that the pH values was significantly in the acidotic range before THAM infusion. It at least went towards the normal range, not exactly in the normal range, but there was significant improvement in the pH or in the acidotic state post infusion. The CO2 content, or the partial pressure of carbon dioxide, did not go up. On the contrary, it went down post THAM infusion with a mean reduction of around 10. And we can look at the THAM dose here. It varied all the way from 0.45 millimoles per kilograms per hour to almost 2 to 3 millimoles per kilograms per hour. And the mean dose was 0.5 0.55 millimoles per kilograms per hour infusion. In 3 out of the 10 patients, THAM was used in a repeated fashion. That means a second infusion was given after the first infusion was over. And even in the second infusion, there was the beneficial effect of improving in acidosis and reduction in PCO2. In 3 out of the 10 patients that I mentioned earlier, THAM was used as a rescue therapy at a higher dose as a bolus, and we see the same favorable effects where the improvement in pH was noted and the reduction in carbon dioxide was noted. Out of the 10 patients, 6 patients had already received bicarbonate before THAM as the treatment for their acidosis. And as theoretically expected, their pH decreased and PCO2 increased significantly. These are the values of pH and PCO2 pre and post bicarbonate infusion. You can see that the pH values, which was the mean of 7.21 plus or minus 0.06, went down to mean value of 7.1 plus or minus 0.04, and the PCO2 values went up by almost 10 points. As I mentioned earlier, in all the 6 cases which initially got sodium bicarbonate, there was worsening of both respiratory and metabolic acidosis. We all know what are the downside of causing hyperventilation. When you are hyperventilating, there is decreased effective carbon dioxide gas exchange, which eventually leads to paradoxical worsening of respiratory acidosis. With each breath, when we use hyperventilation strategy, there is increase in expiratory lung volume, and this leads to increased alveolar pressure, which can exceed the pulmonary perfusion pressure and eventually cause lung hypoperfusion. This concept is very important. So when we do the strategy of hyperventilation, there is not enough time available for proper exhalation, and because of the reduced expiratory time, the alveolar pressure keeps on building to the point that it exceeds the pulmonary perfusion pressure, and eventually there is a VQ mismatch and again lung hypoperfusion. With increased PEEP, there is decreased venous return and decreased systemic perfusion. Now here, this is very important because these are the patients who have fragile hemodynamics and are on vasopressors, and if we are trying to at least maintain perfusion of vital organs, this would be detrimental. THAM rapidly distributes into a volume that approximately equals the extracellular space, and over time its final distribution volume is equal to total body water. The rate of excretion is slightly higher than creatinine clearance. The half-life in a study which was done by Brash published in European Journal of Clinical Pharmacology, the half-life was found to be 16 to 45 hours in surgical patients with metabolic acidosis. In the present study that I'm talking about, in 3 out of 10 patients, the improvement in pH was maintained for at least 24 hours after single infusion, and it was improved during the first 2 hours itself. In the pharmacology literature, where there are laid out guidelines for treatment of acidemia with THAM, the recommended dose is the loading dose of 2 to 4 millimoles per kilogram over 20 minutes, and then the maintenance infusion of 0.5 to 1 millimoles per kilogram per hour for 4 to 10 minutes. This is the recommended guidelines. In the current study, the mean infusion rate was 0.5 millimoles per kilogram per hour, and loading was not given in all the patients. The only difference was the duration was much more longer than the recommended duration. The average duration was 39 hours, and it varied all the way from 2 hours to 96 hours. Just to give you an idea on the duration of infusion, there was a study published in the neurosurgery literature in 1993, where they showed that when THAM was infused at a steady rate of 0.3 millimoles per kilograms per hour for more than 5 days, the incidence of complications did not change significantly. Now, as I mentioned, the THAM works at a wide range of pHs. So since THAM has a higher pKa values and higher capability to buffer acids at a wide range of pH, there is always a risk for prolonged duration of action of THAM and overshoot alkalosis. But the rate of complications in this study was not higher when it was given for more than 5 days also. The current literature does not show any controlled studies, and the current study itself is not a controlled study. It's done on a very small number of patients. There was no exact selection criteria. It was just a reflection of practice. And again, long-term data or data on overall mortality or whether this treatment done in the initial part of critical illness would affect the outcome eventually is not compared or presented. I would just like to show you the side effect profile of THAM, and this is from Lexicomp. It causes hypervolemia and venospasm. It causes hyperkalemia as opposed to hypokalemia, which happens with the usual alkalizing agent. Hypoglycemia. It causes hepatic necrosis. It might cause, let me frame the word properly. It might cause hepatic necrosis. It can cause local tissue reaction when like phlebitis and tissue irritation with extravasation. And again, it might cause apnea, pulmonary edema, and respiratory depression. So these are all the possible side effects, and as we study this medication more, we might come across many more side effects that we are not currently aware of. I would also like to show you one more study that was published in Journal of Nephrology in 2005, where 18 critically ill patients with mild metabolic acidosis, where serum bicarbonate was less than 20, were randomized to either a single dose of sodium bicarbonate or THAM for 1 hour period. And it was found that both the agents had similar alkalizing effects, but the effect of sodium bicarbonate was longer lasting. This is this study experience. Sodium bicarbonate can cause hypokalemia, whereas THAM did not. So when we are worried about hypokalemia, THAM could be a good substitute. When we are worried about hyperkalemia, sodium bicarbonate can be a substitute. But again, all things should be considered before we make that therapeutic decision. What's the current strength of evidence favoring the use of THAM? So the current evidence is not based on any concrete studies or any controlled trials. It's a grade C and level 3 evidence. So the decision to use THAM should be solely based on the practitioner's practice patterns as well as experience. In certain situations where we don't have time to reach to the root cause of acidosis or to correct the root cause of acidosis and the pH is dangerously low, this could be used as a rescue therapy. But again, we don't have any concrete evidence. It is all practice based. The current FDA approval is not there for THAM in use of critically ill patients. It has been used in patients with cardiopulmonary surgery or cardiothoracic surgery, and FDA has an approval laid for that indication only in the short surgical or perioperative state, but it has not been approved for use in critically ill patients with severe metabolic acidosis. So this was just to show you what's there. This might be our next option for management of metabolic acidosis. I would use the word management, not the treatment, because no matter how many weapons we have, we are still obliged to reach to the root cause of acidosis and correct it rather than just mask it by using alkalizing agent. Thank you.